Good evening, everyone. Welcome to this special symposium. My name is Mario Possenti. I'm the Secretary of Federazione Alzheimer Italia, and today I will be the moderator for this session. I'm very happy to be here because in a few seconds, we will talk about a topic that is very close to my heart. Today, we will talk about a project that was born in Italy, but has been developed thanks to a shared effort to many European partners. The project is called RECAGE, and this is an acronym for Respectful Caring for Agitated Elderly. We have three wonderful speakers, Dr. Fascendini, Dr. Yari, and Professor Defanti, will tell us about the project, our structure, what are the objectives, and above all, they will give us an insight of the first data. But let's cut to the chase. We are welcoming our first speaker, which is Sara Fascendini. Sara Fascendini is a geriatrician, a medical director of FERB Alzheimer's Center at Briolini Hospital in Gazzaniga, and co-PI of the RECAGE project. She's an expert in diagnosis and treatment of people with dementia and attended advanced courses at the Center for Applied Dementia Study at Rutgers University. Today, Dr. Fascendini will give us an introduction of RECAGE and explain the structure and the objectives they want to achieve with this project. So let's start the presentation.
I would like to thank Alzheimer Europe for the opportunity they gave us to tell you about our project, RECAGE. RECAGE is a project funded by the European Union that addresses one of the most important problems in the field of dementia, the behavioral disorders. As we all have known for many years, behavioral disorders, the so-called BPSD, cause great suffering, not only for the patients, but also for his family. In this study, more than 20 years ago, it was shown that BPSD were a risk factor for significant financial costs, caregiver stress, excess of disability, premature nursing home placements, and diminished quality of life, both for patients and their caregivers. However, it is important to underline that we often have used a biomedical model, only a biomedical model, to evaluate BPSDs, forgetting that very often BPSDs represent the patient's only possible response to triggering conditions and situations. In this sense, our project represents an attempt to tackle the BPSD problem using a multi-systemic and biopsychosocial approach to help people living well with dementia. The main goal of RECAGE is to validate a special care unit, the so-called SEUB, the Special Care Unit for Dementia and BPSD. This intervention is already present in some countries in Europe, but it is not widespread and it is not yet well studied. So we decided in 2018 to write a project and to present it to the European Commission. What is a special care unit for BPSD? Our definition is this. SQB is a residential medical structure lying outside the nursing home, in a general hospital or elsewhere, where patients with BPSD can be admitted temporarily when their behavioral disturbances are extremely severe and not amenable to control at home. The mission of the SQB is to improve patients' behavior, and its goal is to permit, when possible, their coming back home. How does SQB works? The therapeutic approach in most of the existing QB is a mix of cautious pharmacological treatments, rehabilitative and non-pharmacological therapies, such as occupational therapy, physiotherapy, dog therapy, pet therapy, in an appropriate environment, and with the presence of expert and trained staff composed of doctors, psychologists, educators, occupational therapists, physiotherapists, nurses, and healthcare professionals. In some existing QB, patient's approach is in line with the gentle care of Moira Jones or the person-centered care of Thomas Kitwood. The RECAGE consortium is made up of 18 entities, including 11 clinical centers and 7 associations and institutions. The clinical centers belong to various European and non-European countries that are Italy, France, Germany, Greece, and the Netherlands, plus Switzerland and Norway. And 2 lay associations and 2 institutional representatives from Italy and Greece are also part of the consortium. The project is divided into 3 phases. The first one is an observational comparative cohort study in which we will compare 2 cohorts of patients with severe BPSD. The first one followed by memory clinics with SQB, and the other followed by centers lacking this facility. The second phase of the project is about the adaptation of the model in accordance with the results of the cohort study, not only regarding the main endpoints, but also comparing the different experiences and the different ways to work of the participating centers, and also the different socio-political contexts in which they act. The third and last phase is the scaling up of the intervention. I will now show you some descriptive data of the patients that we enrolled in the study. We were able to enroll a total number of 518 patients, reaching the expected goal. The enrollment phase ended at the end of September 2019 with a little delay. As regards the characteristics of the patient's diagnosis, as you can see, more than half of the patients are affected by Alzheimer's disease, while the second most frequent diagnosis is mixed dementia. As for behavioral disorders, as you can see, people have BPSD of high severity with an average NPI total score of about 52. Let's not forget that in order to be admitted to SQB, patients must have a seriousness that is not well manageable at home. All patients have BPSD of some nature, although non-aggressive disorder, both physically and verbally, are more frequent than aggressive behaviors. In order to obtain the maximal possible dissemination of the activities linked to the project, we organized over time many activities involving local stakeholders. An example should be this roundtable organized in Bergamo, Italy, at the end of 2019, just before the problems related to the current pandemic. The first paper on the project was published early this year. Together with the numerous poster and oral presentation, it represents our effort to disseminate the project. At present time, the project is ongoing, but there have been considerable delays and difficulties due to the present pandemic. COVID hindered regular in-presence visits and compelled the memory clinics to do only or mostly phone visits, with consequent loss of data, withdrawals from the study and delays of the visits, and also deaths to the pandemic itself. For these reasons, we decided to ask for an extension of 6 months of the project. Should it be accepted, the project will last 66 months instead of 60, and date at the end of June 2023 instead of December 2022. At the end of the project, we will organize a final conference during which we will present the result of the project in order to produce a consensus document on a model scope. Thank you for your attention, and let's stay in touch.
Thank you, Dr. Fascendini. It's very interesting to learn more about this RECAGE project. Now it's time for our first speaker, Professor Defanti, the PI of the RECAGE project. Carlo Alberto Defanti is a neurologist, a former chair of the Department of Neuroscience at Niguarda Hospital in Milan, and former vice president of Italian Neurology Society, and presently scientific director of European Foundation of Biomedical Research. In his presentation, he will show us the preliminary data of the qualitative study that RECAGE Consortium is carrying out in parallel to the clinical study. Please, we can start the professor presentation.
In this presentation, I will illustrate the preliminary data of a qualitative study we are running in parallel with the RECAGE clinical trial. Allow me to remind you that the RECAGE clinical trial is only one component of a project aiming at validating, adapting, and upscaling a clinical intervention, the SUB. As such, from the viewpoint of implementation science, the design of our project could be categorized as a hybrid trial design according to Curran. The aims of any hybrid trial are, first, testing a clinical intervention, second, gathering information on its delivery during the effectiveness trial and/or on its potential for implementation in a real-world situation. In this figure, from the Curran's paper, you can see the hybrid design at the interface between effectiveness studies and implementation research. Our clinical trial is a multi-center, 11 clinical center, multi-country study comparing two cohorts, one of them endowed with a SUB and the other one lacking this facility. The units have some definite common feature, a precondition for adhering to the study, but they have significant differences and are embedded in various healthcare systems and social context. Therefore, we decided that a careful analysis of the peculiar features of the participating SQB and of their social context is an unavoidable step for understanding the trial's result. This is why we started a parallel qualitative study consisting in 3 steps: questionnaire about the SUB structure, focus group, and exploring the potential of social innovation and replicability. From the analysis of the questionnaire, some interesting points arose. The specialist care of the elderly with dementia in some countries is entrusted mainly to psychiatrists or old age psychiatrists, Germany, Norway, mainly to geriatrician, France, Italy, Switzerland, whereas neurologists are involved mainly or exclusively in the diagnostic process. Only in one country, France, there is a national web of SUB with more than 100 units, les unités cognitivo-comportementales. In one participating country, Greece, there is no SUB. In the others, the number of units varies from only one, Norway, to 40 approximately, Germany, the so-called gerontopsychiatrische Zentren. The structure of the SUB is not homogeneous. Most of them are located in general hospitals, one in a psychiatric hospital and another one in a specialized geriatric hospital. The number of beds varies from 5 to 23. The length of stay from 18 to 90 days. Two members of our consortium, Athens and Thessaloniki, both operating in Greece where no SUB exists, carried out their focus group without any direct experience with this intervention and answered a set of questions. Here I will report the most relevant. What are the risks and the benefits of a SUB? Both stress the benefits of high-quality care, safety, and relief of caregiver burden during the stay. As regards risk, they point to the sudden change of environment, a potential cause of stress and agitation, but think that this risk can be mitigated through the care of experienced personnel and the involvement of the caregiver in the intervention. What about the use of restraints? Athens distinguishes two kinds of restraints: physical restraints to be avoided in any case and chemical restraints, but all participants agree that the use of medication should be the last resort. On the opposite, locks or password to doors can be used for patient safety and can be considered as rules and not restriction. Both groups underline the necessity of a clear and strict protocol. As regards the patient consent to treatment, both groups remark that in Greece, the problem of legal capacity of people with dementia is not updated. Anyway, when the patients are no longer able to decide for themselves, usually the family caregivers act as decision makers. Does the admission to a SQB entail a social stigma? Both groups acknowledge the diffusion of social stigma in Greece and stress appropriate training and education of caregivers. Both think that a well-managed SQB could not significantly worsen social stigmatization. Concerning the role of the SUB in the general dementia network, they think that SUB could play an important role in this network, since currently in Greece there are no similar units. The implementation of a SUB could be a step towards a better quality of life for dementia patients with BPSD and their caregiver, especially if they are easily accessible to everyone and free of charge. In 6 other centers, 3 of them with SQB, Gazzaniga, Ottestad, Geneva, and 3 without SUB, Mantova, Bergamo, Perugia, the study was performed through expert interviews and focus group involving healthcare professionals and the relevant stakeholders. They were also asked the same question, and in addition, with a view to the conceptual framework of implementation science and strategic management, carried out a SWOT analysis and explored the potential of social innovation and of scalability, replicability. Allow me to remind you that SWOT is an acronym standing for strengths and weaknesses, both internal factors of the intervention and opportunities and threats, both external factors of the analysis. SWOT analysis is a simple but powerful tool for sizing up an organization's resource capability and efficiency and the external threat to its future. Usually, SWOT is presented as a table with 4 components. Another point considered was the potential for social innovation, a topic placed a great deal upon by the European Commission, whose definition is any new idea, including products, services, and models, that simultaneously meets social needs more effectively than alternatives and create new social relationships or collaboration. The third point was replicability or scalability of the intervention under study. Here I will review some point about strengths, weaknesses, opportunities, and threats. Among the strengths of the SUB is the architectural design, allowing patients to wander freely, correctly lighting and colors of walls and floors, presence at least of some pieces of furniture and objects reminding home environment. Closed but masked doors, as in Gazzaniga, or alternatively open doors, touch sensor to enter the unit, anti-wandering bracelets, as it happens in Geneva. Possible direct referral from emergency room, Geneva, conducive to timely help and no waiting list. Good care and continuous education of the staff, use of systematic clinical decision and patient-centered approach. Large recourse to non-pharmacological treatments, strong limits to the use of psychotropic drugs, no restraint policy, only exception when justified, documented, and checked. Freedom of movement policy in Geneva with benefits risk assessment. Among the weaknesses, the fact that some units are not well integrated in the dementia care network. In case of direct referral from emergency room, as it happens in Geneva, there is the difficulty discriminating between somatic psychiatric cases and lack of a mobile team capable of assessing patients before referral to the unit. Other weakness is the possible worsening of the patient's cognitive state due to the change of environment and the possible mirroring effect. The patients are exposed to the agitated behaviors of others. Short duration of stay in Geneva, hence no rehabilitation treatment during the stay. Among the opportunities, the presence of dementia-friendly communities in the catchment area of the unit. This happened in Gazzaniga. Possible admission directly from the emergency room, Geneva. Involvement of the caregiver during the stay and during the preparation for discharge. Continuous training of the staff and training of new professionals. Among the threats, the social stigma due to admission to an Alzheimer ward, the high cost of implementing new specialist ward, and the related problem of cost-benefits balance. The fact that nursing home costs are lower than home care in Switzerland, hence no usefulness in Switzerland of delaying nursing home admissions. And finally, possible competition with alternative interventions like mobile BPS team. As regards the potential of social innovation, according to the above-mentioned definition, the SUB can consider it socially innovative insofar as it satisfies the social needs widely unmet or only partially met. The unit offers to the patient and their families a powerful help in a moment of crisis. In addition, the SUB is a privileged place for training of healthcare professionals dealing with dementia and for training of caregivers. As regards replicability, this issue has been discussed by participants in the focus group performed in 3 Italian centers, Gazzaniga, Mantova, and Perugia. There was disagreement on the replicability on some features. The general structure of the unit and the staff, multidisciplinarity, person-centeredness seems to be replicable, whereas others seem more difficult to implement, at least in the Mantova territory, where it would be necessary to create a new ward with its related costs. In conclusion, the 4 remaining centers are presently running their own focus group. The results of all centers will be discussed during the closing conference of the project and published on an appropriate journal. Thank you for your kind attention.
Thank you, Professor Defanti. It's been very clear what you presented. your presentation. So I have some questions for the speakers that are live here with our participants. So especially for Dr. Fascendini, I have a simple question, but probably not so simple to answer to. So how do you think that a RECAGE project will help improve the quality of life of people with dementia?
So thank you, Mario, for your questions. That is a very important one. As we have told before, BPSD are a very important problem in the fields of dementia. And with the RECAGE project, we imagine that tackle this problem and trying to do some answers and trying to do something for people that have serious BPSD is a little thing, but one thing that can help people and their families to live well with dementia and to give answer to the crisis or period of crisis during their path, during their lives.
Yes, I agree with you. Hopefully, RECAGE will help people with dementia and their caregivers to be able to afford the life that it's presented to them. I have also a question for Dr. Iori. You explain us some data. Do you think that the observed heterogeneity of this data will seriously undermine the study results?
Thank you for this question, which is of course relevant for the outcome of the study. While the observed variabilities, as discussed, is certainly linked to the lack of homogeneous administration of the rating scale, which is a very well known problem, not only in geriatrics, but in all studies focusing on psychometric evaluations. But what is really the most important thing is that the pattern or the scores over time between the two groups is the point that will let us know if the difference which we expect between the two groups will finally end up with a significant difference. In any case, so many factors have influenced, unfortunately, the running of this study that it will be difficult to dissect which are related to the external causes and which are related to the internal causes. So, of course, we will make a deep thought about this point.
Thank you. Thank you. It was very clear in your answer. I have also a question for Professor Defanti. You presented the data of the parallel qualitative study, but how this data will be used within the RECAGE project?
In fact, our study is a typical real-world study, and we expected some differences and some heterogeneities, and of course these issues can impair alter some results of the efficacy of the SUB, but I think that the result will be presented in this complex framework of different healthcare systems in Europe, and probably our study, even if no strong results will come from the statistics, will be perhaps the first one to give light to this not so well known aspect of the treatment of dementia.
Thank you. I have a question. Another question. I don't know. You choose which one of you could respond. But if you look at the future, if you think in 2-3 years, what are the obstacles that the scaling up of this RECAGE project will face? What do you think about it?
In fact, the main difficulty is probably a financial difficulty. In Italy, for instance, we have very few units like the Gazzaniga and Modena unit. We were able to implement these units by changing the destination of some general rehabilitative ward in special rehabilitative wards devoted to dementia. The global cost was not changed and was not augmented, but it is important for us and for the Greek especially, because in Greece there are no units like this. It is very important to offer to the politician, to the administration, a message of efficacy and we hope of cost effectiveness of these units.
Yes, thank you. I think what you told us about the importance of communication, dissemination also to politicians and this kind of stakeholders is very important to make sure that there's a political will to do something about this. I think for Italy and also for Greece, instead for France, there are already SUBs. So I think this is most true for Italy and Greece. But about the SUBs units, have you noticed? We talked about the heterogeneity of the data, but do you notice heterogeneity in non-pharmacological approaches between SUBs and another one?
I can say that every unit has his typical way to answer to this problem, and but I think this is a positive aspect of our study, because now we are sharing experiences and trying to say something common about this big issue. And if we will use one or another non-pharmacological therapy, I think this is not so important. The important thing is that we keep in mind that the people are really important, and persons, both persons living with dementia and persons, healthcare professionals, or everyone is in the SQB. The important is to keep in mind that person has to be at the center of our attention.
So I think it is a real resource at one point, because differences make us more rich. So it's very, very important. So I think that there are no questions from the public. So you were very clear with your presentation and with your answer. So I think it's time to thank our speakers and all participants who stayed us until the end of this very full day and full day of interesting information. So I thank you on behalf also from our speakers, and see you next time. If you want to learn more about the RECAGE, you can connect on www.recageproject.eu. You can learn more about the project and contact the PI and the co-PI. So thank you very much. See you next time.